At Stanford, design is not just making the thing, but making sure you're making the right thing.
The problem started when my son is born. When my wife she delivered in Syria, he was being chewed maybe 3 months early.
You name it, she's got it. She's got a G2, she's got a class 3 bag.
And Russ is a liver transplant, and she was born with biliary atresia, which is no bile ducts.
I think the real problem is a lack of imagination. The U.S. healthcare system is not a research and development institution.
Our goal is to put students in context in order to understand the problem.
This idea that because we know something about physiology, that we there have the solutions to all that ails you. And there's that expert culture, and it's been built up over 100, 150 years.
We have to forget ourselves, and we really have to put ourselves into the place of the other person.
I remember I was like super crazy nervous for the home visit because I was like, this is such a sensitive topic. Like I have all these questions. I don't know if she's going to want to answer any of them. And she just talked forever.
Everything.
Yeah.
Like even though once we have the prescription, we have everything in, it's like, oh, we're still waiting for the insurance to pay or the vendor's taking forever.
Right.
Or,
It's
you know,
all
these things.
You know, Kevin actually gives her a bath while I get everything prepared in the bedroom to change her class 3 bag.
A little exclamation point.
The doctors that I work with here at the D.school love being here because our process is not linear. It's very messy. It's ambiguous. There's no straight, true line to get anywhere in design thinking, and you have to embrace that.
How in like the design world where you're working with a user, potential user, how is that going to be mutual?
Yeah, that's a great question. They expect you to respect what they're giving you.
Okay.
And you're hoping that they will be open enough to actually give you information that is deeper than just surface information.
Yeah, well, the reason that I taught this class was to address the problem of health disparities, namely different health outcomes for people based not on their medical needs, but on their socioeconomic status, their geography, or the color of their skin.
I had a 30-weeker. There is a gap when you bring that baby home from the hospital. It is walking off a cliff. You are terrified. You're not sure if you can care for this child.
And I have 15 minutes.
Right.
So that
We bring the actual users into the classroom to talk to, and we also send the students out to be with the families in their homes and to see what actually happens there.
Because these are very emotional situations for families who have been through very traumatic experiences, and I was really awed by the parents that I interviewed, how open they were and willing they were to share so that we could help come up with solutions for them.
It's actually an attribute to be naive and curious. Because when you're naive and curious, you're looking at a situation with fresh eyes, and having those different perspectives allows them to not only come up with innovative solutions, but backing up, identify needs that very often clinicians might miss.
Yes, yes.
Joseph is getting ready to leave the NICU, and he feels, in the words of one of the parents that we talked to, said like he's about to be dropped off a cliff.
A lot of times parents didn't know when things were going to happen or were very confused, so they could get quick updates through this.
So then in a tutorial, they could have like a tutorial on like doing child CPR or like the NG2 placement or G2 placement. So we created a whole VR headset. It would allow you to look around and see the surgery.
Well, anytime you can put the real world into the classroom, you know, you're already 10 steps ahead, right? So being able to meet with real parents and design thinking that is not in a vacuum of a, you know, behind closed doors, but you're actually getting input from parents and people that are really going to be on the receiving end of what you're thinking about creating is very powerful.
And what the D.school reconnects us to is the art of empathy that is at the essence of healing, and the art of true experimentation that's at the essence of the science of medicine.
And for me, I'm interested in public health and policy, and I think there is a very real need for design thinking in the policy world, which can be very fixed with the institutions that we have, but with design thinking, perhaps there are creative ways to try to change that.
You're never done researching, doing that upfront empathy work, and building something or testing something out really will inform whether you've got that right. So I try not to be afraid of going forward, even if I'm not sure, because it'll just improve my understanding that much more. Provide as much non-medical care as possible.
And then the second piece is I really appreciate how much you guys went to lengths to address the disparities that exist within our patient populations.
What really surprised me was that after 20 years of thinking that I was being a really great pediatric care provider and a really good listener and doing research in health communications, was that these students in 3 months were able to gain key insights about the needs of these families that I was missing day to day in my own practice and my own research.